Okay.
At least lived here forever.
You're live.
All right,
Golf clap.
Mike's alive, and I'd like to call the Budget Review Committee to order. It's Monday, July 22nd, 2019. It is now 7:27 PM in the Aldermanic Chamber. Would the clerk please call the roll?
Alderman at Large Laurie Wilshire.
Here.
Alderman at Large Michael B. O'Brien is present. Alderman at Large Ben Clemens. Here. Alderman Jan Schmidt.
Here.
Alderman at Large David Tenza. Alderwoman at Large Shoshana Kelly.
Here.
And our chairman, Richard Dowd.
Present.
We have 100%.
Okay. And we also have Alderman Jettie.
Oh, also in attendance is Alderman Jettie and, oh yes, Alderman Clee, excuse me.
All right. So the first item on the agenda is public comment. Seeing none. The next item on the agenda is Workplace Benefit Solutions presentation on the city's health insurance. And as you speak, would each person identify themselves?
Good evening, Kim Kleiner, Director of Administrative Services.
Tom DeLacy, Principal Consultant with Workplace Benefit Solutions.
Larry Budrow, Human Resources Director.
All right.
So, Chairman, thank you very much for having us here this evening. I believe one of the reasons that you asked us here was a concern after what we saw in the fiscal 2020 budget. So we know that there was a total increase in the budget of 7.5 million. 3.3 represented healthcare. And we know that that's an 11% increase and that's a problem. And it's a problem with sustainability moving forward for us as we start to look at other priorities that we have within the city. So I'm going to turn it over and ask Director Budrow to tell you a little bit about Workplace Benefit Solutions, and then hopefully at the end of Mr. DeLacy's presentation, we can discuss a little bit on what we'd like to do going forward.
Tom DeLacy's introduced himself already. He is a principal consultant for a company named Workplace Benefit Solutions. The name of the company describes the business that they're in. They consult the businesses in affording employee benefits. He's been consulting for the city of Nashua for 9 years. He's been in the business of consulting for 25 years, and he does so employee benefits consulting for both New Hampshire and national clients. Thank you. Tom?
Good evening. Thanks for having me here. We've got about 25 or so slides to go through. I'll keep it moving along, but certainly feel free to ask questions. It's really your meeting to understand really the history of kind of what's happened with healthcare in Nashua and your health insurance program. We'll talk about some of the challenges that you face and really all employers face in healthcare. And then let's talk about some of the opportunities where we can, as we like to say in the industry, bend the curve a little bit. So without further ado, I'll jump right in. So just a little bit about WBS. So Workplace Benefit Solutions was founded by my partner and myself about 15 years ago. With the advent of healthcare reform, we realized that bigger was going to be better. More resources, more capabilities. It's very interesting when we so in over the course of about a year, we looked at different things, whether they be acquisition or selling our firm to a larger organization. We ultimately chose to sell to Hub International, which, just some stats up there, have over 1 million clients, the 6th largest broker in the country, and Hub is really an acquirer. So they look for shops kind of like ours, and they add on resources throughout the country as needed. Interesting note that when we started with Hub in 2012, we had 2 ERISA attorneys, one on the East Coast, one on the West Coast. Now we have 6 on the East Coast. Just really a testament, I think, to how the business has changed. So really what we do is we take the consulting that we've developed here in New Hampshire with having underwriters on staff, access to actuaries, ERISA attorneys, leave management specialists, and so on. We take our own local resources and augment them with resources from Hub. Just a few of our clients, won't spend much time on this, but our average client is about 1,300 employees. The mean is somewhere around 900 or so, and these are just a few of our clients. We're somewhat heavy in municipalities and healthcare. As we developed our organization, we just wanted to focus on large employers. We don't work with groups of 50 or 100 or 150 employees generally. Your biggest employers in any area are generally the city or town itself and the local hospital. So that's why we really became heavy in those 2 areas. Want to talk a little bit about costs and trend factors. So trend is a term that we use in the industry that's really synonymous with inflation. So when we look at the major carriers in the market, trend or medical inflation year over year for the last 10 years or so has hovered right around 9%. And what this means is if you were, let's say that you were fully insured, meaning you were just paying a premium and the insurance carrier was taking the risk, if they absolutely nailed your claim, expected claims, they got it exactly right, you would expect a 9% increase for the next year. We've managed well below that, and if you think about, everyone is dealing with this. 9% is just not sustainable when inflation is 1.5%. Average raises are in that same 1.5%, 2.5% range. So when healthcare is going up at 8, 9, 10% a year, that just squeezes the balloon for everybody. It squeezes your budget, it squeezes your employees' budgets, it squeezes everyone's. So this is really what we've been dealing with over the last 10 years or so. Where does 9% trend come from? Well, when we look at this, the reality is people will point and say, well, it's the insurance companies. No, it's the pharmaceutical companies. No, it's the hospitals. No, it's this group. No, it's that group. The reality is it's a lot of different things, okay? When we look at that 9%, a portion of it is CPI, just the cost of things going up year over year. A portion of it is drugs and devices, where you might have one therapy that maybe costs, let's say a prescription drug that works reasonably well, might cost $80 a month. Well, a new drug comes on the market and it's incrementally better. Everybody agrees this is a better drug. You'll have a better outcome. There'll be less side effects. Well, that new drug may be literally $700 a month. So it's transferring one for another. It's provider expenses, providers wanting 2, 3, 4, 5% increase, increased consumer demand. If you look right now at the state of New Hampshire, building projects in hospitals, they're almost constant, right? It's kind of like if you build it, they will come. So there's always that increasing demand. So there's no one reason for these double digits or low or high single digit increases in trend. It's a combination of multiple things. And it really is our job to try to control that. Over the years, we've done a reasonably good job. So the blue line is your actual claim cost per employee per year. So that's a measurement that we use so that you don't have changes based on enrollment. So one year your costs are $30 million and you've got 2,000 people on the plan. Next year they go up to $40 million, but you've got 2,500 people on the plan. So that's why we use this per employee per year measurement. The red line is what the number would have been if we were at industry trend for that same period of time. So you can see we're about half of industry trend. But the alarming issue is if we look in the last few years, the last 3 years, we've behaved, or our experiences behaved more like a traditional group. Whereas you look earlier on, we were seeing increases on average 2-3%, which is fairly manageable. And I think we need to take action to get back to where we're controlling costs. And we'll talk about the challenges that we have and some solutions to those challenges. So just a little bit of history. When we started working with the city, you had two different carriers. You offered Harvard Pilgrim and you offered Anthem. And those carriers, that language was built in the contract that said, hey, you will offer we'll offer a Harvard Pilgrim, we'll offer an Anthem program. Well, the carriers knew that. So when we first started working with the city, we saw that your administrative fees that you pay the carrier, and the city of Nashua, level set, is self-funded, which means we pay the administrator, Anthem or Harvard, a fixed dollar amount per employee per month. The claims are our responsibility. But our carrier pays the claims, they provide a network, they answer the phone, customer service, they provide disease management, medical management programs, pharmacy services, and so on. We just pay a fixed small fee for that, and then the claims are the city's liability. And then we have stop-loss protection around that so that we don't get hit with catastrophic claims. So one of the things we did early on is look to the carriers and say, look, we know that there's language in contracts that say we have to have you, but we need a more reasonable rate. And we were able to cajole them into reducing administrative fees. We were able to increase pharmacy rebates. A pharmacy rebate is when a manufacturer sells a drug to a pharmacy benefit manager. Think of Express Scripts, CVS Caremark. When they sell it to them, they get a rebate, or what they would call a concession. Think of it like getting shelf space at a grocery store. You know, that space that's right at eye level, perfect vision. You're paying a little bit more for that if you're selling your product, whether it's Nabisco or whoever it may be. Similar type of things with pharmaceuticals. We were also able to negotiate over time some benefit design changes. So offices at co-pays went from $10 to $20. Inpatient deductible went from $0 to $250 for an individual, $500 for a family. Co-pay changes to emergency room. Whenever we make changes to plan design, there's a certain amount which is cost shift, meaning the employees are paying more for services. But there's a certain amount that just sort of evaporates. Because as things cost more, people are more judicious about how they use them. Well, if my ER is $100, maybe I wait and see if this is going to be better tomorrow, or I get into my doctor's office, or maybe I go to a minute clinic or an urgent care. So I use a lower cost alternative. We adjusted employee contributions, and we've really tried to focus on education so that people understand the value of healthcare and the cost of healthcare and try to make good decisions. And I will tell you, the industry over the last 20 years has made it really hard for people to make good decisions. Because if we think prior to HMOs, everybody had an indemnity plan, right? You paid a deductible, maybe it was a small one, maybe it was $100, and then you paid 20% for the service, the plan paid 80%. But you saw what things cost. Along came HMOs and said, hey, we're gonna make this really easy. Just use a doctor in our network, you pay $5 at the doctor's office, and that's it, you don't have to worry about a thing. Well, people lost touch with what things cost. And I think now we started, maybe 4, 5, 6 years ago, you start to see that sticker shock at the pharmacy where someone would go in and think, oh, this drug's $5. Well, no, the cost of the drug is $260, but you pay $5. So the industry is really changing back to that indemnity mentality to get people understanding the cost of services. And we'll talk a little bit more about that and some techniques we're using. A couple years later, we did another bid on administrators. We were really seeking to try to get to one administrator, but ultimately we stayed with both Harvard and Anthem. We were able to increase pharmacy rebates with both carriers to 100% of the rebates. It was an additional $156,000 in savings. Able to further reduce administrative costs and $80,000 in annual savings, and secured wellness funds that we can use to try to educate employees on using the low-cost providers when possible, try to educate people on having their wellness exams and things like that. Those are not the things that drive healthcare. It's not having those checkups and things like that that really do. We also implemented a high deductible plan with an HSA as an option, so employees can choose this if they want. It's a very attractive plan, and in my opinion, the most efficient and effective way to deliver healthcare for an employer to deliver to their employees. This plan has an upfront deductible with the exception of preventive care. You pay the first $2,000 per individual or $4,000 per family. Think of it like your auto insurance, right? You have a claim on your auto insurance, you have a $1,000 deductible, you pay the first 1,000, the plan pays the rest. But because we've raised that deductible so much, think about your auto insurance again, you raise your deductible, what happens to your premium? Goes down, right? So we raise that deductible, we take that savings, and we use it to fund a tax-free health savings account that the money goes in from the city for the employee can also put money in themselves. That plan is about 15% less costly than the HMO. And really what it does is it activates the consumer in everyone, because any money that I don't spend in that HSA rolls over tax-free year after year after year. So instead of spending someone else's money, now I'm spending my money. So I want to be more careful about it. Maybe I'll take the generic drug instead of the brand name drug. Go to the urgent care instead of the ER. Go to the independent lab versus the hospital lab, and so on. We also, a number of years ago, looked at the post-65 retiree coverage. So you offer a plan to post-65 retirees that sort of wraps around Medicare. And you offered 2 fully insured plans back then and 1 self-funded plan. And we looked at the utilization and said, hey, you're really disadvantaging yourself, because what happened was the more sickly people would stay on the self-funded Medicomp 3 plan through Anthem Blue Cross, which they were used to for years and years and years. And the more healthy people would go to the Harvard Medigap type policies. Ultimately, we also wanted to remove that risk from the city, because the city makes no contribution to that plan. So if that plan runs higher than the rates, higher than expected, the city would actually be making a contribution to that unknowingly. So we were able to negotiate a contract for 1 fully insured Medicare Advantage plan. That plan you still have today. The savings for employees was 20 to 50%, depending on which plan they were coming from. That was anywhere from $100 to nearly $250. So huge win for the employees, and it removed that liability from the city. Oh boy. And that's all we have. I don't know where the rest of the presentation went. I did. Now the whole thing is gone. I do. That's weird. Yep. So you have to put it in presentation mode. Okay. Always good to have a backup. So in 2019, most recently, we performed another RFP. So about every 3 to 4 years, we do this. We were at that point able to consolidate to 1 carrier. So we chose Anthem as the administrator. A couple interesting things here. We added a transparency tool called Smart Shopper. This was actually pioneered in Manchester, New Hampshire. Now this product is offered in 32 states around the country. We added a communications platform called Mobile Health. This is the city of Nashua is the 2nd group in the state to have this program through Anthem. The state of New Hampshire employees is the first. And this is really a tool that we can electronically communicate with employees through their handheld device. And we think that's going to give us an advantage over time of being able to push information to them that will be beneficial for them relative to their benefits, or we could really do it relative to most anything within the city. We also performed a pharmacy RFP. We look at different pharmacy benefit managers because we want to get the best pricing, so the greatest discounts off of brand and generic drugs. We also want to get the best pharmacy rebates with the best medical management programs. We like the idea of having pharmacy carved in, meaning it's with the administrator, because there's an instant flow of data from medical to pharmacy. So they can literally see that, well, Tom's been in the ER 3 times in the last 3 months, and he's taking this medication. There's something going on here. And there's a potential for sort of a minor disaster here. They can reach out to the provider and say, hey, based on these situations, we think Tom might be at risk for a cardiac event or whatever that may be. So having that data integrated, we think is important. But we did go out to a number of vendors, and we really used that as leverage to get the very best deal we could from Anthem through their new pharmacy benefit manager, which they brought in-house, called IngenioRx. We were able to enhance our discounts off of wholesale pricing, and we were able to enhance our rebates. The estimated savings from that RFP is about $1 million a year between administrative fee, pharmacy rebates, and improved discounts on the pharmacy program. The added benefit is one carrier making things just a lot simpler to administer. Okay. So that's kind of the history of what we've done, but challenges are really everywhere in healthcare. And I would say probably the biggest one is consolidation. We're faced with carrier consolidation. We're faced with provider consolidation. Everyone is looking to gain greater leverage. And quite frankly, if we go back to 2012, that's exactly what we were doing. Greater resources to bring to our customers that would make us a better company. A lot of carriers are doing the same thing, thinking about combining, hospitals doing the same thing. We're also dealing with continued increased medical costs and pharmacy spend that is spiking like it did last 12, 15 years ago. And it really is around specialty pharmacy. These are drugs that are coming out at $300,000, $400,000, $500,000 for a year for one individual. So carrier consolidation that was thwarted. You probably remember Anthem's attempt to buy Cigna. That was very concerning for us. I actually testified at the state with the Attorney General's office about what we felt would happen to the market when we have 2 of the biggest carriers now becoming one, controlling over 60% of the commercial market. We didn't really think that that was a good idea. Aetna attempted to buy Humana. Humana attempted to buy Centene. These were all thwarted at the government level, and a big player of that was the AMA, where their research contended that 46% of metropolitan statistical areas had one insurer controlling 50% or more of the market. That's not a good thing for employers. Okay, we want a robust market. We want competition. That drives innovation. It drives better rates and so on. But there was consolidation though in between carriers and pharmacy benefit managers. And I don't think 5 years ago anyone would have thought this was possible. But if you go to the middle, CVS Caremark bought Aetna Healthcare, one of the largest health insurers in the country for the last 40 years. $69 billion. So a pharmacy chain spending $69 billion to buy a health insurance company. That tells you the amount of money that's in pharmacy and the pharmacy benefit managers. Cigna bought Express Scripts as sort of a sort of retaliation or an answer to the Aetna CVS. Cigna and Aetna are very competitors nationally for national accounts in regional markets and so on, and I think similar companies. They bought Express Scripts for $52 billion. Express Scripts was the largest pharmacy benefit manager, touching 1 out of every 5 Americans. This was interesting as well. United Healthcare, their subsidiary, Optum, which is a PBM, a pharmacy benefit manager, they bought the clinics from DaVita Health for $4.9 billion. About 5 years ago, they bought 150 urgent cares called MedExpress for $1.5 billion. So we're seeing carriers get into the provider space, and we're seeing providers become carriers in certain markets. Geisinger down in Philadelphia, or the Pittsburgh, Pennsylvania area, has been both insurer and provider for the last 15, 20 years. We also have provider consolidation. Mass General acquired Wentworth Douglas. Mass General is seeking to acquire Exeter Health Resources. So Mass General, if you're familiar, Mass General Partners, they acquired a lot of hospitals in Massachusetts, and they've basically been shut down from acquiring anyone else because the health system is so big, it's driving the market. And it literally has about a 50% reimbursement advantage over other providers. Disadvantage for the carriers, meaning that the carriers are paying them about 50% more than they're paying other providers, community hospitals, and so on. Elliott Health System merged with Southern New Hampshire Medical Center to form Solution Health. Excuse me. Dartmouth, Hitchcock, and Catholic Medical Center have joined operations, essentially a merger. And Frisbee was acquired by HCA, which also owns Portsmouth and Parkland. And we're going to continue to see that. As carriers get bigger, hospital systems join for efficiencies, but also to drive better reimbursements from carriers, more negotiating leverage. So pharmacy, if we get away from sort of the consolidation challenges, pharmacy is a huge challenge. So if we look at inflation for the last 10 years, it's about 17% in total. In pharmacy, in 2008, pharmacy was 10% of cost. Now it's 19%, a 90% increase. Average cost per prescription was $72 in 2008. Now it's about $126. And the per member per month cost measurement of how we evaluate has gone up 75% from $66 to $116. Now remember, about 86% of your drugs purchased are generic drugs. But if we see on the next page, specialty drugs now count about 40% of all the pharmacy spend. So 1% of claims are driving about 40%. And if we look at this back in 2008, brand drugs were 34%, generic drugs were 65%, specialty was 0.3. Now specialty is 1.1, generics 86, and brand is 12.9. But look where the cost has gone. 40% of the cost is in specialty drug. Yes.
Yeah, I have a question about that, because what do we do about like biologics that are extremely expensive medications?
Yeah. It's a huge challenge, and quite frankly, the carriers are trying to figure it out, and there were nobody's really got an answer now. And one of the things that we talk about is there's a drug out right now that will cure blindness in children. I'm not sure if anyone is aware of this. It's amazing. I mean, we thought amazing 3-4 years ago was we can cure Hep C. Well, that was $100,000 to cure Hep C. If you were unfortunate and you had to take 2 doses, they discounted it to about $190. But this drug will cure blindness in children. It's $1 million. But if your child was blind and they could cure that, who wouldn't say, yep, sign me up? I sure would.
I would too.
So we're at this point where we can cure things that were incurable, but the cost is outrageous. And I think what happens is we end up paying for the rest of the world, because in many countries there are caps on what can be charged for these drugs. In the US there aren't. And the argument would be, well, if you cap the drugs, if we're not able to make money, we're spending $1 billion in research, how do we continue to do that? People won't get the treatments that they need, on and on and on. So it really is a difficult argument. So I don't think that we're going to solve that issue, but I think that there is so much opportunity elsewhere that's where we should focus. There's a lot of low-hanging fruit. I don't think there's an answer for that, and I don't think there will be one anytime soon.
Okay, thank you.
It was interesting. Just a couple days ago, there was a drug called Soliris that came out. This drug treats, and it's called MOSD. Don't ask me to get into all of it, but it's an autoimmune disorder. It's $700,000 just approved. So Medicare is looking at, well, this will add almost $1 per member per month to Medicare spend. One drug. But for that person who needs that drug, it's life-altering, maybe life-saving. So if I've depressed everybody enough, we'll get into some things that are a little bit more positive. So just wanted to give everybody a sense of where the dollars are spent. So when we look at a self-funded plan, we are trying to eliminate taxes, premium tax at 2%, federal fully insured health tax of 3.5%, so on and so forth. So our administrative fee that we pay Anthem for all the work that they do, to pay the claims, to provide the network, to do the disease management, to provide the pharmacy program, on and on and on, we pay about $1 million. That's about 2.6% of our spend. Stop loss is the insurance that we purchase for catastrophic events. Well, it's not even catastrophic anymore when somebody has a $700,000 prescription drug, right? But any claim over $350,000, the insurance company pays that. Each year we shop the stop loss because it's a commodity. As long as we have the right contract with the right provisions, we're fine. And it's completely blind to the employees. We want to get the best deal every year for that. Okay? We don't shop administrators every year. Changing is very difficult, but we make sure they're providing us the best discounts and the best value for the dollar. Stop loss, typically we get somewhere around 50 to 60% of that money back in reimbursements, but it is a spend. And it's a spend that we think makes sense. It ends up being probably on average about 1% of your budget. But when you have that horrible year where you have $2 million in large claims, you're happy that you have that. Okay. Medical claims is $30.5 million. Pharmacy claims are about $7.8 million. Total of about $40 million spent on healthcare. We talked about rebates earlier. Rebates are not in that $40 million number. We get back about $1.2 million in pharmacy rebates. That essentially offsets our administrative fee and a chunk of our stop loss. So when you put rebates back into this equation, we're operating this plan at virtually nothing. The point of this is we've got to get the claims. We've done everything we can around the administrative fees. We've got to get to the claims, and we've got to engage people to do that. So this is a little bit busy. I just have you focus on cost share. And this isn't cost share when you think about what do I pay out of my paycheck. This is cost share where you say, if I have $1 for a claim, what percentage is paid by the plan? What percentage is paid by me, the member? So City of Nashua, and these are Anthem customers, and then the sort of Anthem book of business is customer 5. So City of Nashua is 95.5, meaning that the plan pays 95.5 cents of every dollar spent on healthcare. The employees pay a little bit under 5. Customer 2, another municipality, 92.8. Excuse me, customer 1. Customer 2, 88.3. Customer 3, 92.4. Customer 4, 93. The average customer out there for Anthem, be they fully insured or self-funded, large or small, about 78%. So the important thing here is you have a really, really rich benefit plan. It's one of the richest in the state, richer than the state of New Hampshire employees. That's a good thing. That helps you attract employees. That helps you, help them take care of their families and so on. But let's look at that plan design and say, are there things that we can do that don't disadvantage employees, but do help us control costs? So this is sort of the blunt force trauma approach, I guess I would say. And that is, there are levers that we can pull, and one of them is plan design. Another one is employee cost share, right? What employees pay out of their paycheck. I'm not a fan of pulling that cost share lever. Because when you pull that cost share lever that saves $1 million, and you say you're going to go from paying 20% to 25%, you've just shifted $1 million to the employees. I would rather focus on plan design, where we can save $1 million. You're going to shift probably half of that to employees in the fact that they're going to pay more when they see the doctor or pay for a prescription. But half of that is going to disappear through behavior change. Okay? And this are just some examples. Changing the inpatient deductible and facility deductible to 500 and 1,000, it's 2%. 1,000, 2,000 is 9%. Everybody at the bottom, everybody goes to the HSA, 15%. I would argue that if everyone was in the HSA, people would be better off from a plan design perspective, have more money in their pocket, and you would have a better plan and lower cost. And we're starting to see migration. We're getting there. If we look to a year ago, July of 2018, we had about 420 people in the HSA. In May, we had 480. Right now, we're hovering around 560 with the July open enrollment. We're getting there, but very slowly. Yes, sir.
Yeah, I have a question about that because right now the way, and correct me if I'm wrong, but right now the way that works is it's a $2,000 for an individual. Let's say it's a $2,000 deductible, but then the city gives $1,500
Correct.
back. So essentially, the employee only pays $500. Is that?
Yes, so the city puts $1,500 into a health savings account, which is triple tax-free. So the money goes in tax-free, grows tax-free, and comes out tax-free for qualified expenses. It's kind of the holy grail of taxation. There really isn't anything else like that. So it gives employees, and that money rolls over year after year after year. So it's not like an FSA where you use it or lose it. So yes, $2,000 deductible, you get $1,500 in your HSA, and there's a little savings out of your paycheck, because the HSA is a less expensive plan. I think that's about $150, which we would say to employees, put that money into the HSA, so you have money to pay your deductible.
So my question there is, over the long term, right? I guess where the math in me doesn't jive, or where I can't figure out how that works is, how is it that the city giving $1,500 back on a $2,000 deductible saves anybody any money?
Say it's a city money? Well, you want to talk about the city first or the employee?
I understand how it saves the employee money, but how does it save the city money?
Employees behave differently. So they are more likely to have preventive care. Good thing. They're more likely to follow doctor's instructions. They're more likely to use generic drugs. They're more likely to use an independent lab. They're more likely to use an urgent care. So they're better consumers. And there's so much waste in healthcare. If you look at any publication, everyone will tell you between 50 and 70% of healthcare is avoidable, either by lifestyle, which is a small portion of it, but by going to the right place at the right time, by using the generic drug instead of the brand name and so on. So it's a real change in behavior. And as I've worked with municipalities where we've done this, I've been amazed in meetings where people are telling me after being on the HSA for a couple of years, hey, yeah, I get my drug at the Hannaford drug program, and it's like, I don't know, 80% less than what I was paying. I'm actually learning some different tricks from them, but all of a sudden they're activated consumers. Where I would argue that healthcare in general is the only thing that we buy with someone else's money, and we don't know what it costs. So that really is where you see the big change.
Do you see that though as a sustainable option for the foreseeable future? If the city switched to that completely.
Yeah, I do, and we have clients that are full replacement HSA. That's all they have. They offer a high HSA and a low HSA, and they might offer a third. That's unusual. But I think it is sustainable. Now, I'll back up by saying, if we were to build an HSA from scratch, we wouldn't put 75% of the deductible into the HSA. We would do more like 50%. But your underlying HMO plan is so rich. Remember when we offered the HSA, there was a zero deductible, $10 office visit plan. So we had to have an HSA that was somewhat comparable. Otherwise, people would have kind of laughed us out of the room. But if you think of the HSA, there's two things I can tell you. The healthy people will do very well under it. The very sick people will do very well under it. And then you'll have a group in the middle that it'll be, depend on the year, that they could win or they could lose. But over the long term, I think everybody wins, because when you're a better consumer, it matters. And I'll show you some detail on that. So outpatient surgery costs, a comparison by site. And this is really what I'm getting at. And this is what I think is our opportunity. It's how do we engage the employees and get them interested in looking at these things and making good decisions to help us flatten out the cost curve, okay? So Anthem has a product they call Site of Service, where they basically say, Go to the low-cost facility, it's covered at 100%. Go to the high-cost facility, subject to a, pick a $2,000, $3,000, $4,000, $5,000 deductible, whichever plan that you choose. But look at the cost difference. A colonoscopy, and we saw this with Smart Shopper 10 years ago, City of Manchester. $28.76 at a low-cost provider, $51.45 at a high-cost provider. The difference there could be the same doctor, just a different facility. Facility X charges $4,000, facility Y charges, $2,500 or $2,000, whatever it may be. And that's where you see the difference in these types of services. Upper gastrointestinal, is probably laparoscopic surgery, $5,600 versus $2,100. Arthroscopy, $58 versus $97. A musculoskeletal, so a back fusion, something like that, $7,000 versus $3,420. So these facilities in blue are ambulatory surgical centers. And you're familiar with them, Nashua Ambulatory Surgical, Bedford Ambulatory Surgical, Elliott One Day, they're all over the place. And if you've ever been, and I have, it's a better experience. I mean, if you're otherwise healthy, but you have to get your knee scoped, wouldn't you rather go into a place where if you're sick, they're going to reschedule? They don't want sick people there. Lower infection rates, better outcomes. Doctors are doing the surgery at the ambulatory surgical center, and they're doing it at the hospital. It's just half the cost when they do it at the ASC. Big dollars. So if all of these surgeries that were appropriate, and this is data courtesy of Anthem, if all these surgeries were done at an ambulatory surgical center, appropriately so, you're looking at $2.4 million in spend. If they were all done at the hospital, $5.4 million in spend. Where you are right now over the last 12 months is about 4.3. So this is a huge opportunity where we can change the cost by getting people to the right place. And again, these are places that your employees are using. So we're not talking about substandard care or anything. When I look at a municipality up the road, they were using these ambulatory surgical centers almost 50% of the time. Now we want to get it to 70%. Here, you're using it less than that, there's more opportunity. Independent lab versus hospital lab. This is a huge, huge opportunity, and it is with most groups. If you're going to a LabCorp or a Quest, you can see that it's $15, $16 for one test. Now, tests are usually 5-panel or 10-panel tests, so multiply by 5 or so on. But really, what we want you to see here is look at the cost variation. It's enormous. Between 4 and 5 times, whether you're doing it at the hospital or Quest or LabCorp, or even some hospitals have kind of come down in their pricing. Concord Hospital, for instance, has come down to be competitive because they want to be one of those preferred providers. I think if there's more pressure, others will. Now, this doesn't say, if you're in the hospital, of course they're going to do your labs there. You're not going to leave and go to Quest or something like that. But these are outpatient where you have the opportunity to go to Quest and you get your results tomorrow instead of today. Most of the time, that's fine. If it's not, you have it done at the facility. But we're looking for those opportunities where it's easy for the employee to do that. And look at the costs. We could potentially go from 1.7, almost 1.8, down to under 500,000. So these are some things that we can focus on. I think as I kind of wrap up here, I want to leave you with the idea that there are headwinds, there are challenges. The universe is 9% increase year after year after year, but it doesn't have to be. If we can focus in on particular areas, we don't have to fix the biological problem. Smarter people than I are working on that and trying to figure that out. But there's a lot of low-hanging fruit that we can get after, and it really is the will, the desire, and the ability to communicate with employees and help them become part of the solution. Because frankly, I think the employees don't know any of this. And as much as we try to reach out and give them that information, we need to just keep doing it, and we need different avenues to do it. That's why Smart Shopper is so important. So with the Smart Shopper program, if an employee has to get an MRI or an ambulatory surgical, have their knee scoped or whatever, they can call Smart Shopper. Smart Shopper will direct them to the low-cost provider, and they will get a financial reward for doing that. Lab service, $25. Some surgeries, $500. But we're saving $5,000. And once someone does that, they're hooked, and they're going to continue to do it, and they're going to talk to other people. So I think once people start to understand this, they start to pick up on it, because no one wants healthcare costs to go up and their, the money coming out of their paycheck to go up. So I think if we can continue to engage employees in the healthcare discussion, that's really thing number one. We want to educate on the cost differences where there's no discernible difference in quality. So we're not talking about trading out, an excellent provider for a poor provider. More aggressive steps to educate and get people involved in the HSA. And then we can take that a step further to engage other third parties to provide data that supports higher quality with better outcomes. And what I mean by that is, step one is really Smart Shopper, but step two is, what if we had a concierge program where somebody has to get some type of surgery, where they can call a number and get information on that surgery and not get the lowest cost, but get the best quality, which ultimately will drive lower cost through fewer complications and so on. But it's walk before you run.
Alderman Wiltshire?
Thank you. I mean, I know a few people that work for the state, and, I'm going to get my mammogram, and I'm going to get a check for doing it. I'm going to go get whatever. I have to have an MRI. If I go to that place instead of the hospital, there's a financial incentive, and educating people, and people kind of like that. Hey, I'm just going to get a mammogram, and I'm going to get a check for $25 just for doing it. I mean, it's a matter of educating people, and, whether you go to this facility or that facility, hey, if I'm going to get a check for $100 for doing something I have to do anyway, I mean, I think it's really important to educate people and to move in that direction.
Yeah. Thank you. Yes, sir.
Yeah. So I agree with my colleague there, but I also caution. I know that there's also the case where I know that, if I was to come down, heaven forbid, with a serious illness, cancer, something like that, I'm going to Dana-Farber. And there's no question about it. That's just what I'm going to do. So I'm going to go right up to that. If you're talking about the HSA, I'm going to go right up to that 500 right away. So I think I would agree with you that I think that there are some things that we can change, but I think our proximity to Boston, there are some things that, when it comes to that catastrophic stuff, that we're just not. And it's
Totally agree. Yeah. I mean, the great thing about these programs, they're all voluntary. So we're trying to get that low hanging fruit. I'm going for my annual physical,
Right.
I've got to get blood work for whatever it may be. That's what we're talking about. But
Yep.
we want people to have that freedom to go to the very best. And it may be that going to Dana-Farber is the most cost effective, because you're going to have a better outcome.
All set?
Yep.
Alderman Jettie?
So, one of my questions, and I think you just answered it, you clarified that what we're talking about is not forcing anything upon the employees. We're just trying to sell them into smarter choices, and it would be voluntary on their part.
Yep.
But another question I have is, we're self-insured. I know insurance companies negotiate lower rates with providers. Do we get the benefit of that with having Anthem as managing this stuff? Even though we're self-insured, do they negotiate the best deal for us?
Yeah, so they'll negotiate one contract with providers. Doesn't matter if the employer group is fully insured or self-funded. Southern New Hampshire Medical Center gets, let's say they get $5,000 for an appendectomy. Doesn't matter if it's a fully insured group or a self-funded group.
Okay. And another question I had, you talked about, I think you were talking about pharmacy cost. You mentioned inflation of 17%. How is that possible?
That was U.S. inflation is a combined 17% over the last 10 years. So not 17% a year,
Oh, okay,
Yeah, a total of 17 over 10 years.
okay.
All
Thank
set.
you.
Alderman Cleen?
Hi. Excuse me. Thank you. I've got a couple questions if that's okay. And I'm one of those people that used Basque
Okay.
for a recent surgery.
And you have one of those T-shirts, I'm sure, right?
Yes, and the little teddy bear that you get with it. Yeah, I've got the two T-shirts, a pink one, a gray one. But the question that I have on the $2,000 deductible, that what you referred to as the high deductible. I also have a number of people that I know of with this $200 $2,000 deductible, or sometimes even higher. The problem that they have is doing those initial visits to get up to that. Are you saying that there will be $1,500 in an HSA account regardless of whether they put any money in, or is that a matching $1,500?
No, so the $1,500 is from the city, regardless of whether they put any dollars in. We would always recommend that people put in, and what I typically recommend is fund up to the deductible.
Right.
So let's say you get $1,500 from the city, and then you save $150 out of your paycheck because the premium is lower and you pay a percentage of the premium. Take that 150 and then another 350 and put that into your HSA. So whether you do it, you certainly would want to do it through payroll deduction because you save the income tax plus the Social Security tax. But do that on a regular basis so that you have that money in there. Now, you don't have to spend the $2,000. Most people, the majority of your folks, well, probably not, I shouldn't say majority, probably 35% of your employees will spend under $1,200 per year. So they'll never take a dollar out of their pocket in the HSA. And then you'll have those folks that'll spend hundreds of thousands because they had an unfortunate accident or disease state or so on, and they're going to blow through that $2,000 deductible. But what's going to come out of their pocket is the $2,000 minus the $1,500 minus what they saved out of their paycheck.
Just a quick follow-up. Two things, actually. One for clarification. So if for some reason they didn't heed that warning and putting that extra $500, from the very first dollar, they get a $20 copay. They can use the HSA to pay for that $20 copay? Yes or no?
Well, so remember that if you're in an HSA, the high deductible plan,
Right.
you don't have $20 copays. There's
Okay,
no,
that's
there's no
right.
such thing,
That's
right?
But for whatever the copay would be for a
For the actual
procedure or
cost of
something,
the
yeah,
surgery.
the actual cost of the surgery. Is, I didn't see up there if there was the catastrophic, or maybe I just missed it when I was trying to write down some notes here. Like for instance, in my case, I have Anthem. I have a $5,000 out-of-pocket
Through your
catastrophic
employer.
through my through my insurance. I reach that usually by May of every year. So then at that point, almost everything is covered, more or less. Is there a out of pocket, or is that just the $2,000 deductible?
It's the $2,000 deductible. So once you, and we have presentations, and I'd be happy to come back and go in detail through the HSA if that would be beneficial to you and really anybody who is watching on TV. But you have a $2,000 deductible. Once you've paid $2,000 out of your pocket, by all means, you're using HSA dollars. The plan covers everything everything that's covered by the plan at 100% for the remainder of the year.
This truly does sound incredible, and I do believe in Smart Shopper. I think it's a good plan. Thank you.
Alderman Tenza?
Thank you. Can I ask, is there any way to incentivize, especially the younger workers who are working for the city to join the high, the HSA plan that we're talking about? Because those are the workers who would really benefit from them when they're young and healthy, and collecting this money in an HSA account for years and years and years, that they don't have to tap into, because, I mean, it rolls over, it's their money. If they leave the city, they can use it then as well.
Yeah, I mean, you make a very good point. We can't have a different contribution for younger people versus middle-aged versus older. I think the best way to do it is education, and for them to have that conversation with someone on, here's exactly how it works, here's how it could benefit you. We have slide decks and things like that. We're thinking about brain sharks and little videos that give people the information, but it really is the getting people to come to a meeting to hear about it and understand it, and then talking people at the water cooler. What we have in other municipalities is almost every time I do these HSA meetings, someone will show up and be in the back of the room who's on the HSA, and at some point stand up and go, yep, he's right, I've had it for 3 years, and that's how it works. And I think people feel more comfortable then.
So just to follow up, my family's was covered under the county health insurance policy, which is very similar to the cities for 10 years while I worked for the county. And then after that, I have had the experience of having to go out and get my own health care for my family. And it's not as awful as once you get off that HMO, it's not as bad as it seems. There are out-of-pocket costs that you become aware of. But, again, I think the plan for all the municipal employees who are at home listening, if you could do something like at a bar and get all the young teachers and everything together to talk about this, then that might be a great investment in city resources.
That is one venue I've not done yet, but I kind of like it. I kind of like it.
Any other questions? Okay, I agree that education is probably the big strong point on lowering the costs, and I think that every effort should be made to meet with all of the labor groups to bring this to light, and I would perhaps use a slightly smaller presentation and focus on the savings. And go from there. But as chair of budget, I have some larger questions. This year, we get hit with an 11% increase, $3 million, which is catastrophic to our budget. What was the increase for FY '19? And what do you think the projected increase would be for FY '21?
So answer the first question, I believe it was 6.4 for FY19. So the only way for us to project out another year in the future is really to look at your most recent 12 claims and trend them at carrier trend, 9%. So I can tell you without doing a whole lot of math, it would be somewhere around 9%. However, if your claims over the next 6 months or so trend better than they have over the last year, then you would see something less than that. And remember, we had a period of time after we made some plan design changes where we were at 0, 2, 3. So it's not crazy to think that we could return to that. But it's hard for me. Crystal ball, I would just say it's current claims, trend it forward. And
so we have an account, not a big special revenue account or whatever it is, that we put the health insurance money into. This year, the total is, what did you say? We added 3, what was it? 7.5 million. And that's in an account somewhere that we pay claims out of. So the balance presumably, since the year just started, is at least 7.5 million. Or we put money in periodically. Well, either way, what is the amount of money that we're putting in that account this year, including the additional 3 million that we just allocated?
Okay, so the balance isn't 7.5 currently. Currently, it's about 4.8. And we are currently speaking with both the mayor to see exactly, how, if we want to put some additional funds in there. But what we've done with that account has changed each year. One of the things that we're looking at when we talk about our claims and things of that sort is we are looking at education. Now, what makes it extremely difficult for the city is the fact that we're so spread out, right? So we have so many different employment groups in different areas. That makes education extremely hard. Although Director Boudreau and his group has done an extremely hard amount of work, videos, getting out, wellness fairs, things of that sort. Years ago, so back in 2002, you became self-insured, right? In 2007, you started a joint health insurance advisory group. That was in 2007. If you go back, they issued a report positioning Nashua for healthcare in the 21st century. If you go back and you read that report, you're going to see the same discussion we are having right here, right now. The same type of points is what they pointed out. And that committee or advisory group was some employment boards, some administration. It's important for us to get everyone around the table because you're not going to see any change, whether it be change in how our employees or how they act and spend their money, or whether it be how we look at healthcare and look at difference in options. It's the claims that has to change, right? It's bringing down those claims. That's what has to change.
So the issue isn't necessarily with the negotiated contracts, or is it? And it's more in educating the people on what they have available and what they could sign up for that would save the city
Right.
and them.
Well, so it's very difficult for us from the city, and we have a large group that already looks at this, right? So we work with CFO Griffin and his team. We work with Director Boudreau and their group. But there's not a lot of us working with the other employer boards. We need to do that. We need to have those joint discussions. They need to work with us on educating their people. And we need to have some real discussions on what does plan, if there is plan design change, what does it look like? Is that a road we take? And we need to come up with some really solid recommendations like they did back in 2007. But we kind of haven't done that. They did it again in 2010. They got a group together. I think I was on a school board at the time, so I remember the conversation. And then it kind of stopped. And although they've had great discussion here internally at City Hall, we've done this, we haven't really reached out to these employer boards. They know their people, they know how their people will accept education. We need to join together and look at how we do that. We need to look at how much of our employee group is the school district. That's a group that's very hard to educate only because look at how they're spread out, right? So they're at so many different schools. How do we reach out to those employees? And that's always been a challenge. How do we reach out to firefighters, and how do we reach out to police, and how do we really use the tools that we have, like Smart Shopper, that Mr. DeLacy and his group and the Human Resources Department has put together, and make sure they even know about it. You know, the HSA, that's been hard to educate people on. It's been very difficult to go out and educate people on that. So we need to engage these other entities.
So it sounds like a goal for someone in the city to take on and try to be successful at. It may be complex, but I feel there's got to be a solution. The other thing is, as we went through the budget process rather, And we were very tight at the end. I asked the question of the mayor and Kim in her previous position, well, what if we only put 2.75 million aside for health insurance? And the pushback I got was huge. No, we need 3. All right. How critical a number is that? Is that something that we feel is like a not to exceed number, or is it best guess, or what is the reliability number of that 3 million
And you're talking about the 3 million increase.
increase?
I mean,
Claims.
claims can be a little bit unpredictable, but I mean, you want to make sure that you have sufficient claims to cover your costs. And if you pull money out this year, you may be in a position of needing to replace that money plus what the increase is for next year, because we're constantly battling this thing called trend or inflation. It's happening no matter what. It's what things are we doing to maneuver around that and keep our number lower than the rest of the world, the rest of Anthem's book and Harvard's book and so on. So if you did 2.8 versus 3, would it be the end of the world? Probably not. Could you be potentially setting yourself up for needing a really big number in the future? Potentially, yes.
So the next question that follows then is, if we have a better year than we anticipate, does that difference lower our anticipated amount of money we have to spend next year on health insurance?
So and this is something to be careful of, it lowers your potential increase. It's very, very,
Yeah,
very
that's what I was
unusual
shooting
to
at.
see somebody
Yeah,
going
yeah,
down,
yeah.
right? But yes, so if trend is 9% and we come in just easy, 5% below expected, we'd expect to see an increase of 3 or 4%.
That we could probably handle.
And that's really where we were for a lot of years. And just going to the previous comments, I think we need to get those groups back together to really have a discussion like this, to understand what's ahead of us, because we don't want more years like this. And I think doing the things that we talked about here, we've done them in private employers, we've done them with other municipalities. We can make it work.
So
We just have to attack it.
the other question I have is, and Kim was working on this in her prior life, maybe easier life. We're starting to have a number of contracts coming through the pipeline, as we do always, and there was an attempt, again, back when Kim was there, to make sure that the health insurance portions of that were in line with the current city thinking. Who's got that role now?
So, Kim Kleiner, it's important, and I think that the board has spoken about this many times in the conversations that you've had in strategic planning, right? The strategic planning committee. It is so important for the city to look at union contracts, healthcare costs, all of these things collectively. When you look at them separately, you actually have an increase in costs greater than what you want. So the mayor has asked that we start to look at union contracts and healthcare collectively. So administrative services division working with financial services and working with our employer boards. But it's going to take a joint action of all of our employer boards and our city hall to make this happen. And we need to have those discussions before we get actively into a negotiation situation. But the mayor has asked that we look into it.
Alderman Wiltshire?
I mean, years ago, we, sitting around this horseshoe saying, we'll never get rid of the indemnity plans, we'll never, I mean, it's come around, right? I mean, it had to. And I think the same thing here. You need the HSA because healthcare costs just, and we can't, it's not sustainable, right? But I agree. I think it needs to be done collectively. Every bargaining unit needs to be at the table, with the healthcare discussion, because we won't make progress any other way. I mean, it's 999, you just can't sustain that. But, we thought years ago we'd never get rid of those indemnity plans, and, we've done a pretty good job. So I'm not saying that it's going to be easy. I think educating people, I mean, do people really, they probably just don't know, and they're afraid of change, right? This is what my plan is, this is what it does, you want to change it, so it's going to cost me more. And that's a natural assumption, right? I mean, that's what people think. You're going to change my plan, it's going to cost me more money. You're not going to give me something for nothing. So, I think it has to happen with all bargaining units.
Alderman O'Brien?
Thank you. My ears had perked up when you mentioned collectively, but it's been in my past experience that hasn't been the case. And if that's the way we're gonna go, then I think we should. But the thing is, I really want to make sure we're holding everybody's feet to the fire on it, because it really hasn't been done in the past. And it's one of those things that doesn't get forgotten. It's one of those things when people come up for negotiation in the future, and everybody looks over the fence to see how grass is greener on the other side, and they constantly bring up, and it's been one of those things. So if we're going to do it, I say tally ho, let's go for it. But to make sure that we do it, and honestly, to keep it, because if we don't do it at all, then don't bother. Let them negotiate on their own and try to scrape the best deal as possible, And it's just, I know that's a little editorial, but it has been my past experience with that.
Alderman Clements and Alderman Kelly.
Thank you. To get a change like moving people to an HSA like that, it takes a lot of negotiation, and it takes a lot of political willpower too. Because I can remember being on the board in 2010 and the mayor coming down and saying, we want to go to a $250 to $500 deductible. And you would have thought that the sky was falling based on the reaction that that some people had. And, but it was one of those things that at the time, I mean, $250 deductible wasn't unreasonable at all. And, especially when you looked out and some people were getting, at that time, $1,000 deductible, $2,000 deductibles. That's when they started to come around. And the city said, look, we need to adjust. We need to adjust how we do business. And we can't sustain the $0 anymore. We have to have a deductible. And, it takes a lot of education. It took a lot of political willpower. You had folks like myself and Alderman Wiltshire came out and supported that, and, didn't have a lot of friends on that at the end of that conversation. But, but I think what it does is it makes people understand, okay, this is beyond what, if it'd be great if we didn't have to, if nobody had to pay anything for health care, sure. And if we could do that, absolutely. But, times change, and that was 2010. So we're talking about 9 years ago. I think it's time for another conversation, and I think it's time to have another discussion with folks and kind of get this ball rolling. And I think with the city paying 75% to that HSA, I think that that's very generous. And I would recommend that, if we do move forward, that's what we move forward with. But I think I agree with also Alderman O'Brien that we need to make sure that if we're going to do something like this, that it's fair and that it's across the board. And again, that's not an easy thing to do, but we've done it before, so we can do it.
I think the key is in each of the union contracts, give them the city's package of what's available. They can still make their own decisions. And that's where the education comes in.
Mm-hmm.
But what you don't want is something that's, one bargaining unit has something that's way off the board that's nowhere near what other people have, and that causes the problem.
Right.
Yeah. Alderman Kelly?
So I appreciated your comment about going after the low-hanging fruit. With HSA, I have chronic things myself, and I couldn't imagine sitting there very sick being like, which lab should I go to? So I appreciate that that's more the concern. And I actually really think that making us more consumers, it is one of the few places where you don't have that information and you just kind of, your doctor says, go to this place and you go to that place. So I think that's really important. I want to ask something fairly basic, and it might be actually to the city more, but I'm not sure I fully understand the being self-funded and how that is, is that financially really helping us? What does it look like if we weren't self-funded?
So if, I'm gonna, while I'm talking, flip back to this slide. So when we think of being insured, meaning that we're going to pay a carrier, they're going to take care of everything, there are a few things that the carrier has to deal with. One, you pay a 2% premium tax to the state of New Hampshire. So 2% of your costs right there go to the state of New Hampshire. There's been a tax that's been in, out, since healthcare reform was passed, and that's called we call it the HIT tax, the health insurance tax. And that is a tax of $16 billion. It's gone to $18 billion. Long story short, it ends up being about 3.5% of your premium. So if you're fully insured, you're going to pay 2% in premium tax. You're going to pay another 3% in this tax just before you start out of the gate. Then you're paying these carriers' administrative fees. They're generally about double what we would be paying here. Then you have margin because the carrier is taking the risk. So they're putting down a claim number and they're saying, if our claims are $30 million, if they're 31, they eat the $1 million. If they're 29, they keep the $1 million. You don't get it. So they're going to put in a buffer, usually 2 to 3% on a group your size, to say, well, we think it's going to be 30 million, but we're going to set it at 31 because we don't want to be underwater. So now you're talking another 3%. So right out of the gate, your 2% premium tax, 3.5% hit tax, 3% margin, double the administrative expense. So when we look at this piece right here, we're eliminating all of that. And that's why we self-fund, because we know our claims are going to be our claims. If we have a terrible year and if our budget is $40 million and we end up our budget at $44 million, and we can say, well, glad we were fully insured, but what's our renewal next year? 25%? Carrier's going to get it back, plus all of those taxes. So that's really why any group over, certainly 500, self-funds to eliminate those administrative costs and really kind of control their own destiny. So you can determine what your benefits are. And if you put in programs to lower costs like Smart Shopper, you gain 100% of that value versus the insurance carrier gains that value. So, does that help?
That was very helpful.
Great.
Thank you.
Alderman Wiltshire?
Yeah, again, I've probably been told the answer to this. What is the stop loss? How much
It's $350,000
per person?
per individual. So person, employee, dependent, so on and so forth. But we're big enough to support that.
Okay, so I just asked because where I work, we've been self-funded since '99. And, a small group of 70.
Oh,
And
wow.
our stop loss is 30,000.
Yeah.
So Okay.
Yeah, so
You have
think
a
of.
lot more employees, obviously.
Exactly,
but-
exactly,
Yeah,
exactly.
so that's where the,
Yeah, yeah, so it
350
really
is-
is, look at the claims that we're at almost $40 million in claims,
Mm-hmm.
70 people, you might be at 600 or 700,000. So
About
that
eight.
30,
Yeah,
yeah,
yeah.
so, yeah.
okay, just.
Okay, if there are no additional questions, we can let them go. We have other things to do on the agenda. We have people waiting, so thank you very much. That was very informative. We probably should have done that long before the budget season, but Mrs. Kleiner was kind enough to set this up as soon as she could, so.
Yeah. Thank you for your time, we appreciate it.
Yep.
Thank you.
All right, where are we? Alderman O'Brien.
Would be communications, there are none.
None? Unfinished business?
There is none.
New business resolutions?
Before us this evening is R 19-157, changing the agent to expend on certain expendable trust funds administrated by the Parks and Recreation Department. This is also assigned to the Board of Public Works to appear on the 7/30, 2019 agenda. Mr. Chairman, seeing that it is yet pending to appear before the Board of Public Works on 7/30/2019, I would like to make the motion to tabling R 19-157 pending the Board of Public Works meeting on that said date, 7/30/19.
Motion on the floor is to table R 19-157 until we get a response back from the actions taken by the Board of Public Works. All in favor signify by saying aye.
Aye.
Opposed? Motion carries. It's tabled. Alderman O'Brien.
Thank you, Mr. Chairman. Also before us this evening is R 19-158, approving the cost item of a collective bargaining agreement between the Nashua Board of Education and the Nashua Association of School Administrators and Supervisors, American Federation of School Administrators, AFL-CIO, from July 1st, 2019 through June 30th, 2020, and related transfers. Mr. Chairman, I would like to make a motion and recommend final passage.
Recommendation is for final passage. Would you like to come up and give us an explanation of the contract? This is Mr. Donovan, the Chief Financial Officer of the Nashua School District.
Yes, and this is a pretty simple contract. It's a one-year contract. It's a 2.5% increase for everyone in the group. That's in the budget, so to speak. So they'll be working again on another contract, hopefully for a longer term. One of the things they're looking to do is sort of create some groups or steps. This is an interesting group, and there's a lot of different people. You know, there's directors, and then there's sort of food service people, and so it's a big mix of people, so they want to try to get some better organization and structure around their salary grades. So they're hoping to do that, and they figured a one-year deal at 2.5 would give them time to do that.
So just a couple of things. One, these people have tended to slip behind on the pay because just because of the position they're in, as opposed to, say, teachers. And the other thing is, you said you have the funds for this increase already in your budget.
Yes.
And it's a one-year contract, so that's the budget that's been approved, so there's no additional funds there. Anything else that you wanted to?
Nope, that's all.
And these people are, like you said, directed super. Oh, another question I wanted to ask. Since some of these people have food service, does that portion of the funds come out of the food service account?
Yes.
Okay. Questions for Mr. Donovan? None? Okay. The motion on the floor is to recommend final passage to the full board of R 19-158. All in favor signify by saying aye.
Aye.
Opposed? Motion carries.
And just for your information, the group did vote unanimously to accept the one-year contract. I probably should have said that.
All right. Let's see. Alderman O'Brien.
Thank you, Mr. Chairman. Also before us this evening is R 19-159, authorizing the mayor and the city treasurer to issue bonds not to exceed the amount of $1,300,000 for property reevaluation services. Mr. Chairman, I would like to make a motion of final passage.
Motion on the floor is the final passage of R 19-159. We heard extensive discussion on this earlier in the evening during the public hearing. Are there any additional questions? Alderman Clemmons.
I'm just, for the record, I won't be supporting this evening. I don't find it necessary, and I think it's an expense that we can use money elsewhere.
Any other comments? I just might state that we are under a 5-year reevaluation every year. This is meant to address the next evaluation much better than we did the last one. And that's why the mayor has asked for this money to start this process, to have better visibility and of the entire assessment process and presumably much fairer system. So, any other questions? Alderman Tenzo.
I have a question about the 5-year bond, because Treasurer Fredette said that this is, apparently the state law allows us to bond this expense, and we can do it for up to 5 years. It's a 3-year project. I guess my concern with bonding this is that this becomes an annual expense, and in 5 years, whoever's sitting on the board says again, oh, we should do a new full list and measure at $1.3, $1.5 million, and it becomes a line item in the budget, in the bond debt service that we're paying for. And I just want to be clear about this. The city's not making any money off of this. I thought we had gone along with the statistical reevaluation because that was acceptable to the DRA and because that's, industry standard at this point. So,
Alderman O'Brien.
You
all set there?
I am, yeah.
All right.
Yeah. I think I understand, and if I may, in my attempt to address Alderman Tenzer, I don't think this is an attempt to do something like this in bonding every 5 years. The city has in the past gone through exactly what we went through before with, an evaluation which was basically estimated and everything. And that seems to work out well. But at some point in time, you do get to the point that to see there's people that do go out. I don't think this is an attempt by the city to go out and raise taxes, because I see, there have been people that probably did some work, probably without any malice, but redid a basement, let's say, in the example. Did not yank the permit as such that they were supposed to. And therefore, they increased the value of the property. So that has a saleable income to them. And this is just watching out to play the game fairly to all taxpayers, that if somebody did, let's say, in that example, did their basement over, that the property would be more evaluated to be on the marketability. But again, I think they came up with the bond every 5 years because they know we do the reevaluation every 5 years. But as in the past, I think it's been about 10 years, and I'll look at my chairman, who has
2008,
a lot, but I do remember when we did have somebody coming around, and somebody, might have said 20 years, I don't know. I mean, it's been quite a long time since the city has come up. So it's basically, I think, doing justice to et al. Again, like I say, everybody to come out and have the property evaluated, and just to make sure that it is fair to all.
I think Alderman Jettie, Alderman Wilshire, Alderman Clements, then Alderman Kelly.
So I'm not on the committee, so I don't have a vote, but I would certainly support this when it comes to the full board, and I encourage the committee members here to vote in favor of this. I think that, it's been close to 20 years since we've done this. And a lot of towns and a lot of cities do this constantly. They go out and visit every property. Maybe they do it over a 5-year period. They do 1/5 of their units every year, so that they're constantly updating this information. I think that, we've been told, I don't know if it's accurate or not, but we've been told that there a lot of errors have been discovered in our, property cards or whatever. And I don't know if that's accurate or not, but this is an opportunity to reassure the taxpayers that their properties are being assessed accurately and fairly in relation to everybody else in town. So I think that, and bonding, there's, I've read 2 or 3 different articles recently that municipal bonds are really, the interest rates for municipal bonds are really low right now. They're very attractive to the market, so that's why, we're able to borrow this money uh, very cheaply. And, as opposed to, taking $1.3 million out of the budget to pay for this in one lump sum, doing it by bonding it, taking advantage of the low interest rates, I think it's a prudent way of approaching this. So I encourage the people on the committee to vote in favor of this.
Thank you. Alderman Lucia?
Thank you. I'm going to support this. I don't think it's going to be a year-over-year kind of thing. We haven't done a full list and measure since '91.
Last
So-
time, Mayor Donchis was mayor.
Right. So, I'm in favor of us doing this and bonding it now, but in the future, I don't see us supporting bonding over and over again to do it. But I'm going to support it.
I go out on a limb here because I've had some discussions with the mayor, but I believe the idea is to reset the assessing foundation with this action, and then to plan ahead after '23 and have enough money in the budget to do a 5th every year so that we can keep it current. I think that's the plan. Don't hold me to it, but I think that's the plan. Alderman Clements?
Yeah, I guess that point wasn't, what you just mentioned wasn't explicitly stated this evening. But my fear is that we're being reactionary, and I just, everything inside of me is telling me to vote no on this, because what I would hate the city to be doing is being reactionary to something that is really out of the city's control, in the sense that, yes, the assessments went up last, and the reevaluation happened last fall, and to me they're pretty accurate. I know the one that I got for my house, my taxes went up by $1,200, and I live in the middle of the city on Ash Street. Okay, so but it is what it is, because when I also am able to get all that equity out of the house as well. So I don't think that what happened in the last fall was anything that was out of the ordinary, and I don't see that. I haven't been told, and we haven't been told by the mayor or by Ms. Kleiner that this is going to end up with any other result other than what we would have on the statistical analysis. So I don't understand spending the money to do this if we're going to get the same results. So that's why I can't support this, because essentially we're just spending $1.3 million to make sure that our math is correct. And I just don't think that it's worthwhile to do. And so I will not support this.
Alderman Kelly?
So I have concerns about how the timing was brought up and why it's going to take 3 years where you were talking about 5 years. And I would love a little bit more information on how they came up with a 3-year time frame to do this. I know someone from public comment was like, why not 1 year? So we haven't actually talked to the consultants for 6 months, and I would just love to know kind of why we came up with that number. And I mean, I'm concerned that people who saw their taxes go up this year are going to get to see their taxes go up again a year earlier.
That's why I asked whether there was a proposal for that 1.3 million, because it's a not to exceed.
Yeah.
Which means they don't have to spend 1.3. We're authorizing a bond of 1.3, but that doesn't mean that we have to spend 1.3. It's also a 5-year bond, but we don't have to take 5 years to pay it back if we don't want to. And the reason it's only 5 years is because state law says that for this purpose and this purpose alone, you can only borrow money, bond for 5 years, because a lot of towns and some cities, I would say probably most towns, they don't have the money every year to do this. So what they do is they bond the total reevaluation of their town, which is a lot smaller than we are, and then they do it in one fell swoop and then pay it back over the 5 years. And that's state law. Follow up, Alderman Kelly?
Yeah, just to clarify, I understand the timing of the bond. I'm wondering about the time that they need to do a full measure and list to the best of their ability, and why we're doing it a year earlier than we actually need to even do a statistical analysis.
Well, I assume that's in the proposal as well, that there are a significant number of homes in the city of Nashua to visit individually, each single one, and go through it. We haven't done that in a long, long, long time. What was done this past year was spotty. We wanted to put it off a year and plan better, and the state said no. So, you all set?
Just a final comment that I would love to see what that proposal looks like and what their thinking was before I give away 1.3 million.
I get Alderman Schmidt, and then Alderman Wilshire, right? And then,
As a ward alderman, I must tell you that I received many calls, not so much people saying, oh my gosh, it went up. They're saying it wasn't fair. They were saying this wasn't something that they had done. Their neighbors had the same thing and theirs was lower. I heard it so many times. It was clear to me that using this old data and just doing it through the cards isn't sufficient, and it's time to step up and do the whole thing. I really like the fact that it's going to take 3 years for completion, because that's closer to the 5 years that we would have to do this. So if we can get it done, then we get another 5 years to do this step by step through the whole city. I know this will make a lot of the people in Ward 1 very happy to know that this is going to be done thoughtfully and completely this time. Thank you.
Alderman Wilshire?
I couldn't agree more. I think, because we haven't gone into people's houses since 1991, people that don't pull permits, people that, do all these upgrades and additions that don't get captured, since 1991, I think it's fair. I think people will feel that it's fair.
Yes.
Because we have taken the steps to go through every property. So I couldn't agree more with Alderman Schmidt.
Alderman O'Brien?
Yes, I agree too. And to Alderman Kelly, this is a very labor-intensive type of thing, much more than the guesstimation evaluation that kind of we went through. Surviving, I am a 1990 survivor, whatever it was, of when they came in and did it. But I did let the gentleman, the appraiser, to come into the house, and he looks at the outside of the property, he looks at the inside, looks at all floors. So I imagine is probably they have it figured out how much time per household of what he does, and then he's got to go back and data entry it, put into some form of computer or cottage system or something. So all this taken, so the time of 3 years doesn't seem anything abnormal to me, you know what I mean? And yet I also agreed, I think it's very well spoken with the Alderman from Ward 1, you know, Alderman Schmidt, because this is the fairest and most equitable way to do it. If anybody's got a complaint out there, I think, yes, there's always been that abatement practice, but if we're doing our job and really got a sharp pencil, people who went through abatements will probably find out that their numbers aren't as skewed as what this, when we do the reevaluation come out again, you know, at least the numbers should be reflexive, we hope, you know, so it's, I think it's a great thing. I think it makes it even Steven to everybody. So I support it.
Alderman Kelly, Alderman Clee, and then Alderman Tenzo.
So I hear that and I understand that it is time intensive, and I think not having done it in the city for 30 years, I get that. My question is, if we have 5 years before we have to do it again, why are we doing it in 3? And then that pulls us back 2 years, right? That's when it starts over again. Instead of, we just did it 5 years ago, we're gonna do it in 3 years. Do you understand what I'm saying?
No, we're actually,
I've got,
we're doing this to respond to
early.
the next 5-year timeframe. 23 is when the next one, next 5 years would be done. That's what this is leading up to. So we would have the data ready to go for the next 5-year increment.
so, if I could follow up, from what my understanding was, the question was, does that reset it? And I heard yes. And 2020, we set 2 years back instead of having that whole 5 years. I'm not advocating for taking all 5 years. I'm just saying we're going to be looking at it 5 years, then 3 years, then 5 years. If we go the route
Also,
that we're currently talking.
The assessing process is probably going to go on year to year to year to year from here on out. Alderman Clee?
First, just clarification, she said 2022, which was 1 year. But I agree,
1 year.
I agree with what
Thank
the
you.
point you're trying to make. And I don't get to vote here in this group, but I want to say I'd like to see this happen. I think if nothing else, whether it was a knee-jerk reaction to comments that have been made and so on, putting that aside, I think this shows good faith to the citizens and the residents here that we want to do the best job possible. And yes, there will be people who won't let us into their homes. That's their right to do that. But then their home will be assessed as such. You know, good or bad, that's the way life works here. But I think it's time. It's time to go into the homes, see if the everything that they have done and worked on and so on. I mean, I'd like to say that my house has always had building permits pulled on that, but I've only lived there since, 2013? No, 2000. Sorry, 2003. So, yeah, just seeing this hasn't been done since 1991. A lot could have happened even before I moved in, so.
Alderman Tenzo?
One of my other concerns, that this is supposed to be about equity and making it fair, but with no clear, the people don't have to let us into their homes. And the people who have not pulled permits are going to be the people who say, it's not the people who pull permits who have a nice new kitchen and bathroom who want to show it off to everybody. It's the people who have the basement that's done over that they don't want the city to find out about. And so I think assessing is not an exact science, which I think some people are looking for in the city. I think this is a big expenditure that we would make without really having a sense of what the outcome would be. I mean, I think it would shift some of the tax burden around. It wouldn't increase taxes. It would shift it around. I'm not sure how it would shift it, if it would shift it onto lower income people or higher income people for that matter. But we don't know. We don't know. So I'm hesitant to support this at this time.
So you are correct that the city has a budget and it's X dollars, and the reassessment won't change that.
Right.
It's just when you assess the value, the rate is against the set evaluation of all the homes and businesses in the city, and then a tax rate is set to raise the amount that we have in our budget. So it doesn't, if we find a lot of people that have more valuable homes, doesn't mean that we're gonna increase our budget. And the other thing is, since if this passes the full board, they can start the work as soon as it's passed by the full board. What former Alderman, what Treasurer Fedette was saying, he doesn't have to sell the bond right away. And on any of our bonds, by the way, they have a plan for when they're going to sell them. Doesn't correlate when the work is done, because we pay that out of city's cash account, and then the bond pays that back. So it's a really tricky thing. If you ever want to have a lesson in bonding, spend a few hours with Treasurer Fedette. Alderwoman Kelly?
Just a comment. It's interesting to me. I wonder how it will shift, because the people who don't open their doors are not going to suddenly be the people who open their doors now that we're doing a full measure and list. It's going to be the honest people who are willing to open their doors and come in that are going to see those changes. The people who don't pull permits and don't open their doors are not going to be affected by this.
Alderman O'Brien and Alderman Clemmons.
Yes, and I just want to make, and Alderman Kelly, you're absolutely right, but it's that little sticky document called the Constitution, you know what I mean, that unfortunately gets in our way every once in a while. But, and that's a good thing, but we in the fire department had the same thing. We couldn't go into a single-family home to investigate, to make sure that they had smoke detectors. You would think that somebody would value their lives of their children and themselves and would allow you to do such, and those people do. But we had more legal authority in multi-family type of housing type of situation, because in that situation, the effects of one person could definitely have adverse effects to the other person, whereas a single-family home comes under a man's home is his castle. So it's one of those tough things. I do hope people do open the doors for fairness to their, fellow citizens. That would be the greatest thing that could be done. But I do know it's a little bit of wishful thinking, but maybe I might be wrong. I'll hope on the good side.
Somebody else have a? Yeah, I mean, there's always been, far back as I can remember, and that's quite a ways. There have always been people that haven't let them come into their house. But there are other ways the assessors can sort of figure out what they have. And especially if the house is sold, because you have MLS, and believe me, realtors take pictures of 100,000 pictures of the house when it's going up for sale, especially today. So there are other ways they can find out information, if you don't let them in. But it's a relatively small number, and in the grand scheme of things, doesn't have a significant impact on the end result. But if we haven't been in the homes for a long time, and we have people doing an evaluation from the street, it prompts the concerns that have been voiced by some of the members of the public. And we want this to be as transparent as possible. Doing this full-up system, which we wanted to do before the state said you'll do it by the end of this year or we'll take you to court. We now want to do it the way it should have been done a year ago. So the motion on the floor is to recommend final passage of R 19-159, authorizing the mayor and the city treasurer to issue bonds not to exceed the amount of $1,300,000 for property reevaluation services. All those in favor signify by saying aye.
Aye.
Opposed?
Nay.
Division?
Division.
All those in favor, raise your hand. 1, 2, 3, 4. All those opposed? Motion carries. Yes.
Yeah, could you just record on the microphone, I think, it was a 4-3 vote?
4-3 vote.
Right, in affirmative, okay.
Yes. And Okay,
Did my
so,
clerk job.
new business ordinances,
Uh,
that'd be none.
There would be none.
Tabled in committee, R 18-102 is still on the table. I have received information from the Corporation Council on the proposal that's going from the union to the Labor Board on early August. I forget the exact date. You're not liaison anymore. I think it's the 4th. So that will probably be coming back sometime in August, unless they run into a logjam. But it's still on the still tabled. And R 19-154
Yes.
is, Alderman O'Brien?
Yes, Mr. Chairman, I'd like to make a motion to take, remove from the table R 19-154. May I speak to my motion?
Yes.
Okay. It seems that, Mr. Chairman, at the last meeting, we had a great debate on this and exactly what is the expendable trust for parking, where did the money go into, a special account and everything. And though it seemed to been come up, I did make the motion to put it on the table. But, Mr. Chairman, looking at the room here, I don't see anybody here that could come forward to answer any of the board's questions. So I want to make the motion to take it from the table. But if my fellow aldermen feel that there isn't fair representation to discuss this matter further tonight, then my further recommendation is to vote against my motion to remove from the table and to keep it to a later date.
The rule from the table isn't discussion.
Oh, you can't, no, it's tabling is a.
Oh, tabling is not, yeah, okay.
Okay, remove it from the
Removing it
table.
from the table, I guess you can. Okay,
can,
Alderman
right.
Kelly?
So I'm sorry, just clarification. We're able to comment even though we had said tabling?
Go ahead.
Okay.
Yes. Oh, it's not.
I would be in favor of keeping it on the table till we have someone here to talk about it.
So my suggestion is when the vote comes up to take it from the table, that you vote no.
Got it.
Alderman
Thank you.
Clemens?
Yeah, I feel the same way, and I have a question to you, Mr. Chairman. Did you happen to reach out, or did Sue Lovering reach out to that department, and did we hear back from them?
No. They were supposed to come to us when they were ready to discuss. And I have heard nothing.
Well, that,
And I don't believe me, if Mrs. Lovering has any information, she passes it along immediately.
that I trust.
Yeah.
I find it extremely highly disappointing that we've gotten no communication regarding this legislation. And I will leave it at that.
Any other Alderman O'Brien?
Parliamentary inquiry then. If I made a motion to take it from the table, seeing that I'm getting the gist of a flavor,
You can withdraw it.
I withdraw my motion?
Yes.
Okay, Mr. Chairman, I would like to withdraw my motion.
The motion to take from the table has been withdrawn. Stays on the table. Okay. I'm gonna have to get you a cheat sheet on
I'm reading the sheet.
general discussion? No. No one here for public comment. Remarks by Alderman. Possible non-public, we don't need a motion. Motion, Alderman O'Brien?
A motion to adjourn.
Motion is to adjourn. All in favor signify by saying aye.
Aye.
Opposed? Motion carries. We're adjourned at 9:21 PM. Now you can turn it off and put the screen up.